Welcome to the live session for MRCG Part 3 preparation. I am going to make a small presentation, and hopefully that's going to be helpful. And towards the end of the presentation, we will have an open house for Q's and A's where you will be able to ask questions, and we can have a little chat. So this session is to help you to study smart for MRCOG Part 3 exam, and I'm going to take you through a few slides for this purpose. The agenda for this is basically we will begin by letting you know about us, a little bit about us. We will speak about MRCOG Part 3 exam format, common challenges and their solutions, how to study smart for Part 3. We'll talk a little bit about our Smart Intensive course and special offers for the event attendees. And in the end, we will have some Q's and A's, hopefully to answer your questions. So let's begin by meeting the team. Myself, I'm Dr. Asma Nikki, and I'm the Academic Director, Supervisor and Mentor, and Chief Moderator of Smart Intensive course at BMRCOG. Omara?
Yes, hello everyone and welcome to our introductory session. My name is Omara Ahmed and I'm one of the co-moderators for Smart Intensive course at BMRCOG, affiliated with BMRCOG since 2019 and would love to see you all working with us. Thank you.
Darren?
Hello, a lovely evening. Welcome everyone to this session from BMRCOG. I'm Dr. Daryl Fernando. I come from Indonesia, and I'm currently joining as a co-moderator in BMRCOG for the Smart Intensive course. It's very lovely to see every one of you, and I hope you can enjoy the session. And if you have any questions, please feel free to ask later on. Thank you. Back to you, Dr. Asma.
Thank you very much. So I will begin now formally with my introduction. So a little bit about me for those who are new. I can see quite a few new names. So I thought it would be a good idea to introduce myself formally to all of you. My background, I am originally from Pakistan. That's where I had my graduation from, and I completed my MRCOG when I was working in Saudi Arabia. I am now settled in the UK for over a decade, and this is home now for me. I have completed my master's in medical education from the UK. MRCOG was done quite a long while back, and now I'm due to be FRCOG in a few months. And I have done MBBS from Punjab, Pakistan. Experience-wise, I wear two hats in my in my NHS-based experience. One role is clinical, which is very similar to what you all do in the field of obstetric gynecology or in the clinical areas. But the other role is academic, in which I am an instructor, trainer, demonstrator in different UK universities, and usually my job roles have been like teaching fellows or senior clinical fellow or educational fellow. Besides these, as a part of my academic role and a part of the ongoing CPD in the clinical role, I also have an extensive experience to be OSCE examiner in different universities for different level of exams, including the undergraduate and postgraduate exams. And I am a communication skills tutor. I have also designed and developed the curriculum for communication skills for the medical students. I'm also instructor of basic practical skills at RCOG. I've contributed in a few books. This one is one of the most commonly used book for the MRCOG exam preparation. I have made a significant contribution in this book. The other one is for the written part of the European board exam. And then I have also contributed in the textbook of European board obstetric gynecology. And the chapter that I have written in this book is on clinical governance, specifically audit and risk management. It turns out that I think I quite like these subjects, these topics. And apart from this, people opt for private practices in the clinical areas. I love education to the point that I have opted this as my private practice. So my private practice involves being the founder of BMRCOG, and I am very happy to be privileged to be the pioneer of online courses for MRCOG. I started these courses back in 2010 informally and 2011 formally when I started my website. And also, as a part of my master's, my dissertation was so my special interest in teaching is simulation and technology enhanced learning. And my dissertation was on simulation, in which I proposed the immersion model of learning. And this has been an award-winning model of quite a few learning activities. A little bit about BMRCOG, the platform where we all are meeting each other today. This was, like I mentioned, established in 2011, and ever since I have been pioneering quite a few things, which involves first module-based online course, first mentoring services. I started online workshops trend quite well before the COVID era, and now it is everywhere. We all are very familiar of online workshops, but in those times, it was really a completely new thing. We got CPT accreditation in 2016, and this has been regularly maintained to date. And in 2021, we received an award of Best Online Medical Education Program. We have also been nominated this year for the same award. For the in terms of the courses that we offer, we have courses for MRCOG, quite a few in number, European board courses. MFSRH, if anyone of you is familiar with that, this is the membership of the Faculty of Sexual and Reproductive Health in the UK, and then ST3 training route application and selection process, general interview preparations for training and non-training jobs in the UK, communication skills courses, empathy training, English language and conversation courses that involve elocution courses, just simple conversation courses, and IELTS courses. In terms of support services, we have quite a few support services involving mentoring, counseling services for doctors in difficulty, crisis support services that we have very extensively offered and provided during the COVID crisis time, help desk support services, technical support services, and a resilience support service. You will get to know a little bit more about these as we go along. Now, let's come to the point of today's session, the reason why we are meeting today. So the main aim is to help you understand your assessment of MRCOG Part 3, which is the summative assessment for this qualification. Some self-assessment questions would be lovely to begin with. I would go through these questions and I will allow you time. It would really be very good if you can have your answers jotted down somewhere on a piece of paper, so that is going to help you to get the most out of this session today. So the first question is, think a little bit about what is the outcome of this assessment from examiner's perspective. So when the examiners are assessing you in MRCOG Part 3, what do you think the outcome that they are looking for? Think about it. Jot down your thoughts. You can feel free to put it up in the chat box if you want to. The next question is that what is the examiner looking for in your performance? Now, this question is completely different than the first one. Please pay attention to the questions. First is, what is the outcome of this assessment from examiner's perspective, the outcome. And the next question is, what are they looking for in your performance? One is their perspective, and the second is, what are they looking for in your performance? That's very good. Thank you very much for putting up your comments in the chat box. It's very helpful, and it is going to be very helpful for you to figure out how much do you understand about this assessment. that is actually going to help you to devise the strategies for your preparation. Right. So next question to think about is that what exactly do you need to practice? For example, for the part 3, what do you think you need to practice? What is your understanding? Lovely. Okay. Next one is, how will you ensure that you have covered the syllabus? Okay, very good. Right. I think it would be a good idea if I read down some of the, I will later on reading the answers. Next question is, what techniques will you use to enhance your chances of success? Do you have any ideas, any backup plans, anything that you have thought of already or you would like to think about? Notice that we are talking about techniques. Focus on the word techniques. Well done. I'm not reading the answer, reading out these answers not to interrupt with your thought process. So keep on adding. Now, next question is to think about how much is the gap between your place of practice and the type of consultations that you would need to conduct for this assessment. And then think about how will you bridge that gap. Is it very close to how you see patients on day-to-day basis, or is it in a very different manner? Most of the people are saying huge gap, which is expected. How familiar are you with the UK systems? So you can see that this self-assessment is actually very different for each person. Each person has a different perspective, a different starting point. So please, there's no comparison, no competition going on with anybody. Just understand that it's your self-assessment for yourself. Now, the next question to think about is that how familiar are you with the ONG training style in the UK? And do you think that your practice matches that of a national trainee's level of practice? All right. And There you go. So may I please ask one of the other moderators, co-moderators, Daryl, would you like to sum up, give a little brief of the aggregate of the answers, the majority about these questions?
Yes, thank you, Dr. Asma. I think everyone here comes from quite a diverse background from everywhere, and most of them said that they are not familiar with the systems in the UK, especially with the NHS, and also regarding the study partners and maybe difficulties in studying from reading guidelines and books, like for the part 2 and prepping for the style of part 3. Sorry, Dr. Asma, you're still on mute.
Thank you very much, Dr. Fernando. Dr. Ahmed, do you want to add anything more that you have observed in the responses?
Yes, thank you, Dr. Asma. So, majority of the answers, as Dr. Fernando has mentioned, are about a wide gap between their practice and the NHS practice and what is expected of a Part 3 candidate in the exam. Apart from that, in the beginning, the first few questions, I think majority were just concentrated on communication skills, which they need to practice more. So that is also just one thing I feel they are concentrating. Just a couple of persons mentioned about safe practice, which I think should be emphasized more. So these are a few things which I think we have to emphasize more.
Thank you very much. Right. Thank you, guys. I hope that this is going to be a very good start for you to be thinking a little bit in terms of these questions. So going through further the slides, think about what was your initial understanding about these questions. Where do you think you stand at the moment? And then we will see what is the way forward to that. Now, moving further. So what is MRCOG Part 3 exam? Now, the next couple of slides are essentially the slides that I have copied, pasted from RCOG website. So this information is available to everybody. But what our aim is to see that how well do we actually understand this information. From the responses that we have already received from you, you know that you have a little bit of mix, despite this information being available to the public, to you as well. Perhaps there is a little bit of need to understand it in a bit more depth. So looking at this, MRCOG Part 3 clinical exam aims to assess the candidates for that how they apply core clinical skills, application of these skills. It's not the knowledge of these skills. I noted that quite a few responses in the chat box was about the knowledge and the background knowledge. Please understand that your knowledge was tested in part 2. Now it is very clearly written in the first sentence, in the opening sentence, that it is the application of the core clinical skills that is being tested, not your knowledge. Your knowledge was tested till part 2. Now they want to see how you actually do those things that you know about. The next thing is that these skills will be tested in the context of your three main things: skills, knowledge, and attitudes. So it's not just your knowledge. These are your skills. This is an assessment of your skills, knowledge, and attitudes as well. And these things will be assessed in the capacity of these 5 domains, out of which the communication domain can be aggregated as one, which is what I normally do. I see communication as one domain. However, communication is very different. It's a different way to communicate with the patient, different way to communicate with families, different to communicate with your colleagues, different to communicate if you are talking to the examiner. Also, the communication varies from situation to situation, whether you are communicating in an emergency or you are communicating with somebody in a clinic setting, in an outpatient setting. So we are going to look a little bit more in detail about all of this. Talking about the format of assessment, we all know that there are 14 tasks in this exam. But what to focus here is that you will be assessed in all of these 14 tasks. You will be assessed 3 to 4 domains per task. And the important part to understand is that what they are assessing you for, read it carefully in a way that it reflects your everyday clinical practice. and which will eventually mean that you will have to show all of these domains interlinked in one consultation. So the trickiest part of this exam is that the exam comes in 14 modules, one task per module. However, the assessment will be on your skills, attitudes, behaviors on across those domains, across those modules. That reflects your day-to-day practice. How do you actually do those things on your daily basis? Which means that it is your reflex practice that is being assessed, and in a way that all these domains are interlinked within within this one setting, one task and one setting. So each task will be assessed under these domains. It is becoming a little bit more complex now as you go into details of what it means. This is easy. We know that there is a simulated patient or a colleague task, so which means that either you will be teaching or talking to a colleague, or you will be conducting a consultation with the patient, or there will be a structured discussion task, which means that you will be talking to the examiner. It is different than Viva, because in the Viva there are set questions that they ask and then you just answer. Now Viva mindset is changed to structured discussion, in which it's like a discussion. The examiner talks to you. They don't have the set question. They have a guide how to structure that discussion, but they may give you some sort of prompts, where needed, and then the discussion may evolve, although it will remain within the same. So it's not the set questions. They can ask the same question in any way, but while keep maintaining the structure of that discussion. And there is one more thing which was recently taken away from the online exams, but I'm expecting it to be coming back because there is no change as of now on the college website, which is about the linked tasks, which mean that one task can be linked to the next one. And this may mean that it will be a continuity of that. For example, you have seen a patient in labor, and then the patient reached a certain stage of labor, let's say full dilatation, and on the next task, the same patient is now about to deliver and you have to deliver that patient. Or it also explains here and says that the linked task could be to undertake a writing task. For example, maybe writing up a consent form or taking a consent from them, or completing another form, writing a prescription, or any that kind of thing. So it's not very clear what kind of writing task it could be, but it could be there could be a possibility of these kind of tasks, and you need to be prepared for all of these. Now, as you can see, that looking into the detail of what is this exams format, there are quite a few challenges that you can expect. You might have already started to gather that your original understanding of the self-assessment questions is slightly that needs a little bit more in-depth, developing a little bit more in-depth understanding by understanding what exactly can go wrong while you are preparing for that. Now, I have divided this part in some general challenges and some domain-based challenges because this is how it is going to be. The general challenges that I normally come across in such a long period of my coaching for MRCOG exams, people are quite confused where to start from. I think quite a few of you, although you know what the exam comprises of, you know there are 14 modules, you know there are this many domains, but how to start, where to start from, and where to catch the corner from, and then what and who to follow. You know that there are loads of advices, loads of courses available. It's sometimes become very difficult to identify who is giving you the right advice because of course, everybody do have a good reason to give a certain advice, but understand that not every advice will be applicable to you. And maybe a better idea would be to understand that who you need to follow and what you need to follow based on your particular needs. Another challenge is what to study. Like if some people said that your understanding is that it assesses the outcome examiner is assessing is the knowledge. Or the background knowledge. We know that now after reading the college information that they are assessing you skills, knowledge, and applied clinical knowledge and the attitudes and behaviors. Now, how to study these things? How do you study about skills? How do you study about attitudes and behaviors, right? This is something to think about, and these are the challenges, practical challenges that people face. The next one is how exactly to study. Now you know, okay, what to study, but then how exactly to study, that's another challenge. Followed by what to practice. Quite a few people said that the technique. Then when I asked about what techniques do you have, do you think that you will apply, you said practice. And what to practice? What exactly do you need to practice? Then how to practice is another question, and you get to thinking about these points only when you actually start practicing. And then you know, okay, I'm practicing this, but then am I practicing it the right way, or is there another way that I need to follow? How long is enough to prepare? People often find it difficult to some people cannot even do it in several months. They keep on postponing their exam, and some actually do it in a couple of weeks. So that also varies from person to person. Biggest challenge that I have seen from the answers, that there's a huge gap in where you practice from what the UK practices. So working in a different setting, clinical setting, is a very big challenge, which is not your fault, not your mistake, not anyone's mistake. Every system is designed on a different healthcare framework. So it's not about right or wrong. It's about working in a different system and sitting for an exam for a different system. And this is a big one, lack of support. This is the biggest challenge by far, which is all of the other challenges underpin to lack of support. If you get the right support, I'm sure that you will find answers to all and solutions to all the other challenges. Now, moving on to the domain-based challenges. First and foremost, how to merge the domains and modules. We know 14 tasks and we know the 3 to 4 domains. How do you merge them? And we know now, looking into the details, that it should reflect your day-to-day practice. And in our daily practice, we don't think about domains or modules when seeing our patients. Anyone of you do that? I don't think. Nobody does that. We see patients, and then they are assessing you in a way that it reflects your day-to-day practice. That is a very big challenge. Then in every domain, what exactly are they assessing in each domain? Okay, communication skills perhaps is the most widely understood domain. People understand that they assess for verbal and non-verbal communication. But what about the other domains? What about the safety domain? What exactly is safety translated as in the UK system? So this is also another challenge to understand. A very big question to people is that, shall I prepare topics, domains, or modules? What exactly to prepare? You know, there are domains, there are modules, and then there are topics. The exam come in the form of topics. So what on earth are you going to do? How exactly are you going to prepare all of this, and how are you going to grasp all of this, right? So, sorry, I need to move this from my screen. Yeah. And if someone of you have had a previous experience of sitting in the exam, then and it turned out to be negative, if any one of you has that unfortunate incident, then of course it's a big question that makes you think about that. Why did I fail in a domain? What was the cause of that failure? And you keep thinking about what exactly could be the reason for that. So the commonly failed domains are three: applied clinical knowledge, communication domain, and safety domain. It's needless to repeat it again and again that actually all the module domains are interrelated. One is linked to another. So by not including information gathering here does not mean that information gathering is not a domain that is not failed. But normally when people fail in one or two domains, then these are the common ones. Information gathering usually comes in a failure when someone fails all domains. So the common ones are just a couple of domains. The reason for failing each of these domains: applied clinical knowledge is failed when you do not know the UK systems, which means that in your consultation, you are not applying the UK system. For example, referring the patient through a certain pathway, acting in a certain way. For example, if someone comes with a post-menopausal bleeding, and you say everything, you include everything, but towards the end you do not put her on a 2-week wait pathway and do not refer her for immediate assessment or further sampling or whatever, then that is going to fail your applied clinical knowledge. It doesn't matter what you know, because that knowledge that you have delivered so far is actually the bookish knowledge from part 2 that you know. But if you are seeing a patient, now you are seeing the patient right in front of you, and this patient's safety is directly your responsibility. So if you do not put this patient on a 2-week wait pathway, of course, it's a big safety compromise. And you will fail that applied clinical knowledge domain as well as the safety domain. And then if so there is certain margin. You don't really fail the whole exam by failing a domain in 1 or 2 modules. It has to be consistent on over like 4 or 5 modules. This is why there are 14 tasks, 14 different examiners assessing you through the same domains, so that to make it fair and so that the assessment is across. It's the like a quality assurance kind of thing, that you know that you definitely lack those things in that particular domain, which is why you have failed. So if someone fails in applied clinical knowledge domain, this means that it's more than 4 or 5 stations where they have actually not been able to reach up to mark. But for safety domain, you can fail the whole exam even if you fail the safety domain in 1 task, because safety is a massive issue. It really depends on the type of error that you have made in this exam, but it really varies on the instructions that the examiner might have received. For example, if I'm examining year 1 or 2 medical students, and if it's let's take an example that it's a task to, the station is about a physical examination for something, and they fail to wash their hands before approaching, I have to fail them, and I have to complete a form that is to notify the rest of the team that this person has failed here, and they will fail the whole exam regardless of whatever they do. So for MRCOG, it's not to that level, because of course that is a very basic level of learning things. We are higher, much higher than them. So depending on what kind of safety error have you made, for example, if you do not put a patient who is on a suspected pre-malignant, who could have a pre-malignant state, and you fail to put them on a 2-week wait pathway, then that definitely accounts for your failing the whole exam. So it's you need to understand that how does it work in terms of from the examiner's perspective. Communication, it's a reason for failing is people. There's a tendency that sometimes people learn, they rehearse some like in a dialogue fashion, which is not communication. It's a aggregate of several factors. What communication is, we know that okay, there is a verbal communication and a non-verbal communication, but essential is to understand British culture, the language and the wording that are used in this country, the body language and the consultation style, not the communication, but the consultation style. It's a completely different thing than just communication. And of course, safety is when you are not familiar with the clinical governance. Clinical governance is a big thing in this country. And that is that involves, but is not limited to the non-technical skills, for example, team working, leadership. Reflective practice is a very big element of that, because that accounts towards being a safe doctor by reflecting on your own practice, identifying your own mistakes, identifying the areas where you need improvement and improving, making those improvements, re-reflecting and confirming that you have made that improvement, and the workplace-based assessments. So there are so many things that are, tiny elements that are actually the reason that form the reason for failing these domains in different scenarios. Information gathering, a big misconception is to consider it equal to history taking. Information gathering is far more than just history taking. It is not equal to history taking. Lack of clarity about the concepts of empathy. Usually it is mistaken as sympathy. Usually empathy is considered as using the phrases that I understand this is a difficult situation for you. I can see that you are angry or upset, or I will try my best to help you, or these kind of things. This is not empathy. These are, so it's not the words and phrases only that are empathy. Empathy is very different than sympathy. Empathy is to understand other person's perspective, not to say words or things that are just, showing that you are sympathizing with them. But when you are understanding their perspective, then you are able to provide and offer them solutions based on what are their circumstances and what are their difficulties. So please understand that you really need to clarify your understanding about empathy if you want to pass this exam. It's crucial. Then, like we already said, that there is a wide gap in the approach. The national trainees, the way they practice for this exam is completely different than the international medical graduates. We all are IMGs, and we have no idea about how they actually don't prepare for part 3, to be honest, because what they do is their day-to-day practice. That is the preparation for part 3. They get their feedback on their real life patients. Whereas the IMGs, they consider it sometimes as a desk study. They have to sit and study for this exam. That's not how it is. That's a very big challenge indeed. Then another challenge is that outside this country, I don't think that any other training program has the workplace-based assessments like the UK. In your training, I don't think that you are required to have an X number of clinical case reviews, X number of reflections on those case-based studies, X number of mini-CACs or the OSATs. I don't think that that is a requirement in any other system. So all of this is, oh, I'm really sorry. It appears as if I have, it's definitely overwhelming, and it appears like shocking that you have to deal with so many challenges. But I did promise that there are solutions to these challenges. And once you understand what the challenges are, the next step is to understand what you can do to overcome those challenges. So for this purpose, I believe that the most important thing is to understand what are the step-by-step from small questions, what to do, and then the bigger picture of that. So let's see how to do that. In order to where to start from, the simplest solution is to follow a disciplined and a structured program. Don't go haphazard. Have a structure to what you're going to do. What to practice? You need to understand what the examiner is looking for. What the examiner is looking for is basically they are, when you are sitting, the outcome that the examiner wants, these are the people understand that after passing their MRCOG, they will be coming back to these departments as a senior registrar. After 2 years, they will become a consultant. So the outcome that the examiner is looking for is that, do I want to hire this doctor in my department? That is the outcome that they are looking for. That is what they are assessing you for. So the skills that they are looking for are, of course, your leadership skills, your decision-making skills, your team working skills, your overall professionalism, your ethics, and of course, your clinical approach towards. So it's a whole complex. So when you understand what the examiner is looking for, what the skills they are looking for, what the outcome they're looking for, then you know what to practice, what exactly to practice. Having the solution to having too many conflicting advices, really, it's entirely up to you. You are an adult and you need to think wisely before enrolling on any courses. Nobody can force you to enroll on any course. It's your time, your exam, your money. You need to make that decision. You need to understand your personal needs before you follow any other person's advice. Yes, gather advices that you need, but then find the most suitable advice suiting your circumstances and your needs, and then stick to that one advice. Stop being a traveler of two boats at the same time, because if you put one leg in each boat, you are definitely going to drown. You cannot reach the destination. You have to take one single boat that matches your way of learning and your needs, because that's the only solution to do to go through that, and it is entirely in your hand. Coming to what to study, because every person has their own different study needs. That also depends on how long before you have completed your Part 2 exam. We are going to talk about that a little bit more in detail in a while. Moving further to how to practice. So you need to find someone who can give you constructive, honest, and elaborate feedback. keeping in view what the examiner is looking for. So how to practice, the right way to practice is to practice with someone or in the presence of someone who can look at your practice from examiner's perspective, just the way the examiner is going to look at it. And also you need to start reflective practice, because that's the only way you can bridge the gap between the UK systems, UK style training and your own training. You have to be your own, you have to rely on yourself, and you have to be sufficient for yourself in order to get this practice, a success. Who to practice with? Study partner is a big question. People are often quite frustrated about not finding the right study partner and how to find the right study partner and who to practice with. You really need to find someone who is similar minded and who has a similar approach. Two people from two different courses, sometimes people think that, okay, I joined this course and you joined this course, so we both get benefit from both courses. I will share with you what I learned from this course, you share with me what you learned from this course. Yes, this is a wise approach, this is a good approach, but then what happens in the end is that you are stuck between two conflicting advices. Quite often there is no right and wrong approach or advice. Like I said, every person is an individual, they have their own individual needs. But what will happen is that that conflict will not help you any further, because that is going to put you in the constant state of not knowing what to do. Is this right? Is that right? This is not what you need. You need a straight path. You need an understanding what you need to do, and then you need to do that thing consistently so that it becomes a reflex behavior, and you are able to show the examiner that this is how you do in your, because it is, they will see how you will be reflecting what you do in your daily life. So you can reflect that only when you do something consistently and with someone who is similar minded, with similar approach. And it's a good idea to practice with someone who is a professional with a UK practice experience, of course, because they will guide you the best about the UK systems. Studying in Part 2 style is a big problem, and I am going to after the initial few solutions, and I'm going to talk at length about the difference between studying for Part 2 versus the studying for Part 3. The time scale for adequate preparation is really very variable, depending on your baseline practice, baseline skills, attitudes, and behaviors. It is usually sufficient to have 5 to 8 weeks, even less if you are more prepared. Longer than that, yes, even that is okay, depending on what your needs are. So every person, like I said, has different needs, and it will vary from person to person. Now the big question about that, there are 14 modules and the marking is domain wise. So how to deal with this thing? You need to learn the techniques to merge domains into modules, and we will talk about this as well. Covering topics versus covering domains. To address this issue, you need to learn the specific systems around each module so that you are able to cover any topic from that module if you know the systems per module. I call it module mindset, and we will talk about it a little bit later. Now, how to deal with the commonly failed domains? What you need to do is to familiarize yourself with all the underpinning skills. Like I said, the UK systems, clinical governance skills, different communication skills, and then practice along lines of those skills rather than just practicing randomly and just doing things haphazardly. It's very important and very handy to have support from people who are working in the NHS. Also, understand information gathering is not equal to history taking, and history taking is just a part of information gathering. Information gathering is the new style communication. The history taking is a part of it, and it's a very old style way of conducting a consultation. For quite a few decades, the new way consultations are conducted is through information gathering. Lack of clarity about the concept of empathy, I can talk about it endlessly. And I am going to reserve it for some point later, otherwise it will become too much. In short words, sympathy and empathy are two completely different things. Empathy is a skill that you need to learn. Empathy is something that is very, very specific to the Western culture, specifically England, the United Kingdom. And empathy is something that they learn from their cribs since they're born. And we start to learn about empathy when we start preparing for this exam. So our standard, we really need to work hard to match the actual empathy standard. Empathy is not sympathy, just remember that part. And how to apply various domains. Of course, if you know for each module, if you have a mindset and if you have a template that, okay, any topic falling in this module will be dealt with one single mindset. At the end of the day, all you need to memorize and understand is 14 module mindsets. And then you should be able to cover any topic on earth based on that module mindset. In terms of reflective practice, I mentioned earlier that you need to reflect regularly, be your own critique, and it's a very good idea to discuss your reflections with a mentor if you have one, because then you find ways of how you can improve. Reflecting on yourself and being your own critique is far more softer than having a feedback from somebody else, because a feedback, no matter how sweet it is made, how sugar coated it is made, it comes hard on adults, because adults are not used to be told off for not doing a certain thing a certain way. It's very difficult for adults to accept feedbacks, no matter what technique you use, how soft you try to make it. So reflection is a good way to do that. Being your own critique actually saves you a lot of hard feelings that a feedback can bring. But it's very important to discuss your reflection with another person, because then it will further soften the impact of that self-reflection, and you will learn the right techniques that you need to and the right areas that require your improvement. For the wide gap of your training versus the national trainings, then you need to know that how exactly do the national trainees prepare for the exam and try to adopt their approaches if you can. Lack of professional feedback on individual performance, that is, of course, it is also a part of not working in this country, working elsewhere. And of course, you do have an option to find a reliable trainer who has an experience in giving feedback on workplace-based assessments, because workplace-based assessment feedback are essentially a feedback on reflective practice. Workplace-based assessments are not something where a trainer observes you performing an instrumental delivery or doing a very difficult cesarean section. Yes, that is a part of it. They are standing there, they are observing you, how you're doing. But then after that, you need to send them, you need to log a ticket from your e-portfolio in which you reflect on what you have done. You give the whole scenario, you reflect on your practice. I would just need to switch. So you prepare you write a little bit of the case, then you prepare your reflection, and your reflection is expected to be your reflection on your clinical skills, your reflection on your behaviors, your reflection on your the non-technical skills. How did you do as a leader? What did you do as a leader? What did you do as a team worker? And all those things, and then the trainer gives you a feedback on your reflection. So it's quite tricky. It's not just that you do and then you go there and I tell you that, okay, you did not do this right and you did not do this. It doesn't work like that. It's a very different way of training. So the main difference between part 2 versus part 3, that is very important to understand. And I hope that after understanding this difference, you will know that what you need to do. So this is, if you understand this prism, which is called the Miller's prism of clinical competence, maybe it's a good idea to warn you that the next few slides are quite technical from the medical education point of view. So I'm going to explain you the underpinning ideas and why the differences are there. So to begin with, all the professional exams, this is not just for MRCOG, all the professional exams are designed based on Miller's prism of clinical competence. So this prism basically helps the assessors to identify basically the skills, attitudes, and behaviors. And the assessments are focused to identify on different areas. First is your know. So if you look at it as a pyramid, you see the foundation level is knows, which means the knowledge. So your knowledge is assessed. then the next step is know how is assessed, how something is done, and the further. So these two are assessed in the part 2 and also part 1. So the know is SPAs, assesses your knows. They are very straightforward questions, and they are knowledge-based questions. They are factual questions. Does this happen? Does this not happen? This is the incidence. This is the etiology. This is the risk factor. This is the complication. Factual knowledge that you just know. But then EMQs are designed to assess your know-how. How do you actually approach a problem? You have several guidelines. Let's say a scenario is that a woman who is 43 years of age with a BMI of 42, and she is a primary parent, and she has a type 2 diabetes, and she is there in labor, right? And the scenario is asking something. You have to apply all of these guidelines to identify one simple answer to the whole. This is what EMQs are, from a long list of questions, right? So you need to be able to know how will you intercommunicate all those guidelines. So it's a critical thinking process, a higher order cognition test that so your know-how is assessed in this level. But then moving further, the upper two levels, which is shows and does, this is what is assessed in part 3. You are gone past the level of know and know-how. So another thing to note, in the shows and does, the focus is on behaviors, whereas in the knows and know-hows, the focus is on cognition. Now, this is not something that I am saying. This is something that Miller's has proposed, and this is something that all professional exams, they follow through during their assessments. A little bit more about the process when you are novice, when you start getting into any field of competency. For example, let's talk about MRCOG. So you begin as a novice, and your aim is to be an expert. Your aim is to become a consultant, right? So it's basically a spiral learning curve. It's not a straight learning curve. You go through a spiral, and the curriculum is spiral as well, which means that you have same 14 modules across the 3 parts, part 1, part 2, part 3. All of them assess you through the same modules, but the domains are different. So the part 1 is focused on completely different set of domains. Part 2, same modules, completely different domains. Part 3, same modules, completely different domain. And it's only after that when you reach so overall, through this process, you are assessed through 12 domains, and then you reach the moment of glory, becoming an MRCOG, and finding all that. Mostly we focus on that moment of glory. I want to be MRCOG, and we ignore the process. How is it going to happen? But if you shift your focus to the process, trust me that the moment of glory is very, very near. You will reach there, because you will have that this is a spiral learning curve. What I have done in part 2, these domains are assessed. I do not need to. I have to build further on it. So it's like a building blocks. You don't leave those things behind. You carry those domains and incorporate them in further new domains, so that then you can show them. So part 2 domains, these are the part 2 domains, right? Diagnosis, investigation, management, and epidemiology. And part 3 domains are these, which is the applied clinical knowledge, patient safety, information gathering, communication. Looking at it closely, just like I said, it's like building blocks. All these 4 domains of part 2 actually are aggregated in just applied clinical knowledge. And they are not assessed in the same way. You have to include your diagnosis, investigation, epidemiology, management, all of these you have to include in your applied clinical knowledge. Then further three domains are added over there, and that's how you build up on that. So if you keep hanging with this part of the exam, you are never going to move past this. You have to move forward. You carry along the basics. You carry along all the steps that you have gathered through, and build on them and show the new skills that you have gained. Bearing in mind, part 2 is cognition, part 3 is behavior. They are assessing your behaviors towards the clinical situations, towards your patients, not your knowledge. Because if your knowledge is needed, you cannot apply, you cannot use knowledge without applying it. If you know a treatment, you should be able to provide that treatment to someone in order for your knowledge to be applicable. So that's the whole idea about it. Let's look at it through a practical example. This is a scenario, 29 years old, para 0 plus 2, who presents with lower abdominal pain and bleeding per vaginum. Her LMP was 5 weeks ago. Her beta HCG result is 1250 international units. An ultrasound scan doesn't show any intra or extrauterine pregnancy. So when you are approaching, we will approach the same scenario from part 2 perspective and then from the part 3 perspective. When it's about part 2, what can be the question in the exam, and what will be the expectation of the examiner from you for that question. So this scenario, if it is an SBA, the question will be either to one of the domains. Either they will be assessing your asking you about a diagnosis, about some sort of information, management, epidemiology, and if it is EMQ, then it will be, usually they will ask what will be the next step in the diagnosis, in the management. Sorry, what is this I for? I'll just quickly remind myself. Investigations, yeah. Right. So it will be the next investigation, most suitable investigation, the next step of management. It is about, so this is how, same scenario, the question will come from part 2 perspective. Now let's see from part 3 perspective what happens. First of all, you will have to deliver the results to the patient. Same scenario. It's not that you are not asked about one single question. You will first need to deliver the results to the patient. Then you will need to explain the diagnosis to the patient. What diagnosis? What does these results mean? Then you need to allow the patient time to absorb that information and voice out their concerns. You should be able to address their concerns. Then you need to gather information from the patient, which is a combination of history taking and other information that you need to gather. Then you need to develop a shared care plan, not just what you know about that. In part 2, you know, okay, this is the next step of management, and you check that answer. But in this one, you know what the next management is, but you cannot decide on that management unless the patient is also on board. You have the proper consent of the patient. You have given, and the consent has to be valid consent, which means that you have given proper information to the patient and adequate information that allows them to make informed consent. And it is your responsibility to assess that the patient has the capacity, mental capacity in that particular situation to make that decision. And only then you can arrive a shared care plan. And only then is the time that you involve others as well. So it's not just you. You will have to involve your consultant, or you will have to involve the social services. So many. So it's as you can see from this simple example, same scenario. The first questions were about your knowledge. No, in the SBA. Know how in the EMQs. But this is you will show the examiner and you actually do those things. So this is the main difference, and this is what dictates your study strategies for these two parts. You have already studied for part 2, you have already passed part 2. Your main challenge is to digest this difference and devise the study strategies for part 3. For this one, once again, I will just give you a very quick comparison. I do not intend to go into the details of this. The study strategies that I recommend, basically SQ3R technique for the part 2 and the transfer of learning technique for part 3. It's very technical. I'm not going to go into a lot of details, but just a very quick for your understanding that when you study for the part 2, the SQR technique it involves surveying the question, surveying the topic, then arriving at some questions, then reading it, then reciting it, and then revising it. But how does it work? What happens is that when you do this thing repeatedly, you put a sensory input, it registers, you forget, then you do it again, it goes into your short-term memory, you still forget, then you repeatedly do rehearsal or revise, and eventually it transfers into your long-term memory, because of which you are then able to have a large store of long-term memory that you apply in the exam. So for the part 3, it is the transfer of this long-term learning, that the long-term memory that you have. You need to now transfer this cognition, the knowledge that you had in your long-term memory, into behaviors. This is the transfer of learning technique for the part 3. So you already have all of these from the part 2, which is your cognition. It's already there because you have passed part 2. Even if you want to doubt yourself, please go ahead and doubt about your knowledge, whether you remember or no. But trust me, that knowledge is present in your long-term memory. It needs a little bit of revision or a little bit of reminder, but in a different perspective. So you really don't need to go back and start revising the guidelines. You please don't waste your time in doing that. Yes, you need to go through the guidelines if you need to, if you think that your knowledge might be rusted and you need to fresh it up, but the way is different to do that. Now you need to transfer this cognition into behavior and show to the examiner how you are going to do that by your communication, by applying that knowledge on the patient sitting in front of you, gathering focused information, not just asking every question in the template of history taking, and then making sure that you are delivering a high quality care and your plan is safe for the patient. And all of this is like a vicious circle. The cognition is reflected, is transferred into your behavior, and then it connects to your long-term memory, and it's a vicious circle that carries on, and you end up into doing what you needed to do. So this is another graphical understanding of what carries a high risk of transfer failure, with the low risk of transfer failure, and optimal failure. So I'm just going to explain this to you quickly in simpler language if I can. So you first make an intention to transfer, which means that right now, like for example, you are now understanding that part 2 is cognition, the part 3 is behavior, and what you need to do is to transfer the cognition into your behavior. So you make an intention that, yes, I need to transfer my cognition into my behavior. You make an intention, and at this level, if you are sitting in an exam when you have just made the intention, you have a very high risk of transfer of the failure of transfer, which means that you will not be able to do things reflexly because it's a show and do level. So you will not be able, because the transfer has not happened, you can only show and do when the transfer has happened from cognition to behavior. So after this, you initiate the process. You actually start applying that transfer on day-to-day basis. You remember, okay, this is how I need to do what I know, and then you repeatedly keep doing it, which leads to partial transfer. Slowly, gradually, your cognition starts transferring into your behavior. Then what happens is that you reach a level where you have done it enough times that you are able to do a conscious maintenance, which means that you remind yourself that today or while performing this task, I have to show these skills, right? So it's a conscious maintenance. At this level of conscious maintenance, it's still a tricky level, but then you reach the unconscious maintenance level, which means that you just do it without even reminding yourself. It becomes a reflex habit. So the conscious maintenance level and the partial transfer, this level is acceptable transfer from exam perspective. You can pass the exam depending on how good you are at your nerves and how good you are to sustain that pressure for 3 hours and constantly remind yourself for all the transfer that you need to do and you need to show. But the safest is the unconscious maintenance, which means that when you have formed a reflex behavior. Now, how it is done. Now, this was the technical side. Now, I will show you the practical side for part 3, how you prepare for part 3. So the first step is to know what to do. Then you do it simply. How to conduct a consultation. For example, we discussed the scenario of the pregnancy of unknown location. Then you simply know that in this one, I now need to first deliver the result to the patient, then assess her concerns, then gather information, arrive a shared care plan. So you know what to do, then you actually do that. Not just that you know, but you actually do that. So next time you see a patient, you actually apply those techniques. Then you ask somebody for a feedback that, okay, how did I do? Based on that feedback, of course, then you make some decisions and you decide, okay, I need to change something, and then you redo the same thing, of course, with more improvements. Then at that stage, you reflect. You reflect on that, how did I do? And it's at this level of reflection. When you reach this level, that's the time you can only reflect when you are able to do things independently. And that's the time when you reach this does and show level and the moment of glory. So it's a very simple process if you understand which is very, very different than part 2 exam. I hope that this is making sense. And this is exactly what happens with repeated failures. People do pass exam, part 3 exam as well, by failing a few times. But with repeated failures, what happens is that you with the part 2 exam, you go through the same process of forgetting. So by failing the exam, you keep revisiting the same topics again and again. Eventually, it transfers in your long-term memory, and you pass the exam. And what happens with part 3 is that this process once again happen over and over and over again, which eventually results in your that you actually achieve the conscious and then the unconscious maintenance of the skills that you have learned. Once again, no other solution, but you just learn by hit and trial what worked last time, what did not work last time. Unknowingly, you actually reflect, you receive feedback, you reflect. It's better to do that in intentional and in a planned manner, so that you can very easily consciously take yourself through the spiral learning curve and transfer it from cognition to behavior and do it in the right manner, rather than going the wrong way and repeated failures and then doing it. There is no shortcut, unfortunately. You have to go through this spiral, no matter how quickly, no matter how you want to do it. That's really, but there is no shortcut about that. And like I said, everyone has a different starting point. So maybe somebody has a different starting point, and their journey is shorter, your journey is longer, really depending on what the starting point is. Now, at this point, I would like to talk a little bit about the Smart Intensive course, in which I'm talking about the module mindset and the immersion learning model. So basically, in the Smart Intensive course, I have incorporated the immersion learning model, and the mindset is incorporated in that. Smart Intensive course has two components. One is the academic component, and the other one is the support component. This is to address all the challenges that you have in your the general challenges and the domain-based challenges. For the academic component, it is based essentially on this understanding that I just spoke to you about. This is the model of the lesson plan, and basically the immersion model is what is applied on this lesson plan. I will explain this to you in a while. So basically, what is Smart Intensive course? It's a 8-week long scheduled practice, structured practice, group practice. It comes in the form of a group, which is a simulated long distance training program. So it's a training program. It's not just simply a course. It is structured in a way that you will be able to, at the end, the experience that you will have in the end will be of that of a national trainee, national level of training and medical education. So the way the activities are designed is they are 100% exam focused and targeted on the Miller's competence, so that you can provide the examiner exactly what they're looking for. And there's no chance that you don't really need to go through the repeated failures from the exam. All you need is a conscious decision of an understanding to begin with, what you need to do, why you are doing a certain thing, do it the right way, and get through the first time. Through these activities, basically what we do is that we identify every individual's needs and then offer them customized solutions according to their needs, with extensive feedback. And our feedback is timely, accurate, and actionable. We provide practical solutions to how you deal with those problems. Essentially, we are doing what we can at the level best. The next thing is the ball is in your court. You have to act on those things in order to get the best out of it. The feedback that is given is domain-based feedback, and of course on every module, but it is focused on domains, and it is offered by all of us. Three of us have special interest. My special interest is in medical education. Umara's special interest is in medical ethics and professionalism, and Daryl's interest is in leadership and management. And they will be talking to you in detail about their specialties as well. So you receive a very high quality feedback, not just a feedback, a very high quality feedback on all these domains with practical solutions that you can apply. And there is a lot of chance for you to improve yourself and bridge the gap between the UK-based training level and wherever you are practicing. Because essentially through these simulated activities, you get everything at your doorstep. Wherever you are, you get the real life experience through these simulated activities. The activity is rota based. So we make a rota. You are given this in advance, like a week in advance. So you know exactly what you will be doing. If you have other activities scheduled, you are on call or whatever, you can always swap your activities with somebody else. So you actually never miss it. The timeline is very manageable, very flexible. Everybody, we all are working. We all are from different time zones, and the way it works is usually applicable and doable for most of the people. And with these activities, we cover up to 120 scenarios for the exam. The live sessions are recorded, and these recordings, this ensure that you never miss anything at all, and you have an access to these recordings up to 1 year, which means that if you, for instance, you decide that either you decide or you don't get a place for November exam, you will still have all the access to whatever you do in the next couple of months for the next 1 year whenever you want to sit for the exam. So far, we are the only course offering online skills and drills. I don't think that I don't know any other course who do online skills and drills. In Smart Intensive course, we do online skills and drills. So practically, how does it work? I will just quickly take you through a lesson plan so that you can have an idea of how does it work and what to expect. So it's a group study, and the lesson plan is based on the immersion model. What happens is that you are required, so you will be given a schedule for the whole activity right in the beginning of the practice, so you know what is going to happen in the next 8 weeks. The course comes with e-course. So this is an interactive course, but there is a foundation course that comes with it, and those are e-modules which you are required to do pre-reading. So the lesson plan is for, let's say, one module. So you are required to do pre-reading before the module begins. So you have some idea of what to expect, how to think through that module, and what is the module mindset that you need to take through. Then there will be a brief in which I will further explain what the module mindset for that module is. How does the module mindset work? What is the module template that you need to use for that module? And that module template will be applicable to any topic that falls in that module. Then we move further to a supervised scenario selection. This activity basically helps you to understand how to place different topics under different modules, because then later on, as you go along, you will realize that a given topic could be under any module. How would you know that which module mindset or which template do you need to use in the next 10 minutes? So this is what we focus on, the supervised scenario selection. And essentially, when we are doing this activity, I am helping you to understand what to do in the initial 2 minutes of reading the scenario. Because when you are reading the scenario in the exam in the initial 2 minutes, you allocate a module, and then you enter the scenario with that module mindset, and you know this is what I'm going to do regardless of what that topic is. This further leads to scenario performance. You are allocated already scenario performances, and you will perform the scenario. Then you will receive an individual feedback on that scenario, which I have already explained that it is domain-based feedback, followed by live plenary discussion and a recap of what we have done. Now, all of this is not happening in one day. It is happening on different days, and we will give you the rota for that. How does it work? But I'm telling you the lesson plan of a module. It's not that it's all happening in one day. Plenary live discussion will recap, answer your questions, any queries, followed by we will also compile the module related topics, so that you are, before ending that module, all the topics that are related to that module, you actually discuss and decide, okay, this topic falls under this module. That makes your life much more easier. Then you get access to the recap notes and recordings, which of course is for 1 year, and also follow-up plans, reading resources, and there is an option to engage in reflective activities as well. So through this practice, what happens is that a lot of, you can see the immersion model is that through these activities, it's a combination of interactive discussion, teaching, clinical governance elements, clinical relevance of your thing, which covers the applied clinical knowledge domain, your awareness about the UK systems, because I explain those in detail in the live sessions, information gathering, communication, safety and quality domains, your non-technical skills of leadership and team working. So we are incorporating all of these within them, and also lots of revisions of the same module, of the same concepts, opportunity to clarify your confusions, receive feedback, ask questions, clarify any doubts if you have, and if you have not been able to attend a certain activity, then to catch up, through the recording and whatever. And as you can see that through this model, clinical skills, applied clinical knowledge, and non-technical skills all are learned within the same setting, and you are able to connect everything, and you are able to know how to show the examiner all that you know about. So after that, the support component of this group practice. So there are several elements of support that are included in this. You have 365 days of free mentoring, because with the e-course, you subscribe for that automatically. On subscription, you have a free learning needs assessment meeting. Needs assessment meeting is what it is called, NA meeting. You have a free personalized learning plan, every person. So I will sit with you and I will have a discussion with you, and we will look into your particular needs, and we will devise and agree on a plan which is very, very personalized to you. We have doctors in difficulty support for those who have certain reasons. So doctors in difficulty is a big thing. We don't fail because we don't know a certain thing. We fail because there are things coming in our way, because of which we are not able to give our best to the exam practice. So we deal with that in our doctors in difficulty support. We have a free resilience support. We have 365 days free technical support with this course. With you have the opportunity of resubscription discounts should you need to, and then you also receive a learning need discount. We will talk about it a little bit later. So what are the results from the Smart Intensive course? And the results are not just limited to passing MRCOG, the results are beyond that. So people who have attended have 100% pass rate, provided they apply, they use it. Of course, I can't say that you can just enroll on the course and you will pass. No, you have to do your bit. We are doing our bit, but those who do their bit, 100% they pass without any exception. And you can refer to the website for hundreds of testimonials confirming this by evidence. You learn the skills that match the level of national trainees. You have a very easy transition if you move to the UK. I have several students who moved to the UK, and then they contact me later to tell me that how easy it was for them to adjust. I myself see many people coming from abroad and then struggling a lot to adjust in this system, and actually they sometimes need to go back because they are unable to cope in the system. So I can see that how the Smart Intensive course people are actually, because you get such a good experience of simulated practice in the UK, that when you come to this country, you actually literally don't feel any difference. You know everything that is happening. The only thing is that then you are, instead of simulated environment, you are experiencing it in real. You have a very high chance to get into the training programs. We have started the ST3 route training program courses, and I'm very pleased to inform you that we have. Am I still audible? Yeah, sorry, I clicked something here. I'm very pleased to inform you that in next week, the new training batch that is starting, we in the top 10, we had the top scoring candidate was from our course, and from the top 10, we had 3 candidates in the top 10 from our courses. So you have very good chances for that. You can stay in touch for as long as you want to, and I'm very happy to support you through your journey in the UK, whether in the training post or non-training posts. You are completely ready for the exam in 8 weeks because we already have a structure. Everything is available for you. All you need is to give a little time on daily basis, which actually pushes you to make that commitment, and you can definitely ensure that you are ready without missing anything. and everything will be ready for you. You cover everything within this time frame, and it also helps you in your personal development by so many other skills that you learn, for example, the non-technical skills, and you will know that there are so many other things that you learn. People very typically say that they have transformed as a person while being in the Smart Intensive course. We usually start seeing the difference in the personalities and the behavior after 3 weeks, the first 3 weeks, because any change of behavior anyway requires 21 days, something to do consistently for 21 days. This is evidence based. So, personal development and, of course, social networking, you get to know a lot of other people and you get in touch. And, of course, it's networking is a big thing. I would now like to hand over to my colleague, Dr. Daryl Fernando.
Thank you, Dr. Asmaniki, for the amazing and insightful presentation for everyone here. Good evening, everyone. My name is Dr. Daryl Fernando. I also have a background of a master's in management and master's in hospital administration, and I'm currently as a co-moderator in the Smart Intensive course. Next slide, please. Right. So a few background checks that you need to know about me is that I'm coming from the same place like each and every one of you. Coming from Indonesia, being an RCOG for the exams or being a member is not a requirement here. So it was personally my own goal. And I passed my part 2 in 2018. And due to the COVID, I took the part 3 in 2022. It was a huge 4-year gap. And I remember when I joined and I had the initial assessment and discussion with Dr. Asma, I was so anxious about missing everything and forgetting everything that I have learned for the part 2 because of the 4-year gap. And being here in Indonesia, there was no study partner, there was no consultants to guide me as well here because they were not familiar as well with the RCOG standards. But being with BMRCOG, it was a first time pass, first attempt, and then I passed with BMRCOG. And giving my background also in management and healthcare administration, it really helps, especially in the modules of the clinical governance, about the audit, about patient safety, everything that you need to know. That was maybe you have read it briefly during the guidelines, in the Green Top guidelines, but how you apply it in the scenarios, in the clinical settings, in the discussions with the consultant, it will show how you apply your leadership and your managerial skills, and then they will know that this patient is safe with you and you can manage this patient accordingly, not just prescribe and diagnose something without all the other aspects of the patient. And then, as I told you before, I passed on the first attempt with Dr. Asmaniki, and I'm also the first MRCOG in Indonesia without any prior work or study experience in the UK. So if I can do it, you can do it too. Next slide, please. So my SIC experience was I had no idea at all how to prepare for MRCOG Part 3, especially with the 4-year gap from the Part 2. I had several books, I kept reading them, and then I didn't even know how to start a consultation. I was like, hello, and then I don't know what to say. So why did I choose BMRCOG? I think I said this repeatedly with Dr. Asma, and maybe Dr. Umar has also heard it, but maybe I think it was God's will. Like I got a seat for my Part 3, and then I immediately searched for courses online for MRCOG Part 3 because I knew this is not going to work if I'm going to study myself for it. And then I stumbled upon BMRCOG on Google. I saw the testimonials. There were several teasers and how about teasers and like examples of how the courses are in the BMRCOG. And then I immediately signed up. And then ever since, everything has been a very smooth sailing ride with Dr. Asma. I immersed myself in the SIC. I followed Dr. Asma's guidance. What is really important is to keep an open mind and willing to change. It is very, very important. So make use of every meeting, every feedback that is given to you. It's mainly for your own refinement until you reach the ultimate goal of passing the exam. I got a lot of feedback also from Dr. Asma and Dr. Umara because, as you know, practice without feedback is fruitless, especially in this Smart Intensive group. The feedback, sometimes when you see someone performing, you can give them feedback. You say you're missing this, you're missing that. But once you're on the hot seat, once you're performing, maybe you would also repeat the same mistakes that what other people have been doing. So getting the same feedback from the same mentors, you would get what the idea is, and then as you go along, this will become a memory that is already in your core. So you don't need to memorize everything; it will be more repeatedly. And then I got lots of new friends and study partners, like-minded, same focus. All of us passed, and we're still in very good touch up till now. So I can say not only friends, but also a new family with BMRCOG. Next pointer, please. So my best experiences and personal favorites. There are a lot of courses that I signed up for in BMRCOG, but Smart Intensive course was the opening gate for me. I loved how the feedback style was from Dr. Umara. She was very detailed from A to Z, from how things went smoothly, what can be improved. So you not only get the negative points, as like Asians, usually we like to focus on what went wrong, but also what was well was also focused on how we can improve ourselves better. Resilient support, Dr. Asma noted that I was prone to burnout, and then she gave me lots of points on how to prepare for the exam. And then there was also the audiobook, which was also a game changer, but the audiobook is more of a later if you decide to join. So if you start the beginning from the audiobook, you need to understand about the module mindset. And then the one-to-one session with Dr. Asmaniki, this is very important. It really gives you a chance to be on the hot seat and really perform, not with a friend, but like with an examiner. So you know how the real exam experience is since 2 or 3 months before the real exam. And then they were all very friendly, very approachable. Discussions are always happening in the WhatsApp group. So there is no other group, and the support is unbelievable. Next slide, please. So what to expect from the Smart Intensive course? First and upmost, it is an adult learning. So it is not like we are giving you guidelines, read this, read that, but it's more comprehensive than you think. So it's not only covering the study materials, but it also challenges your leadership skills, your communication skills, and other soft skills that are also extremely important for MRCOG Part 3. Because I remember that just memorizing the guidelines is not enough, but how you talk, how you have empathy, how you react to the role player, all of this you can get it here, not just by having someone dictate you to say this or say that. And coming from a managerial background, this SIC helps me apply my leadership skills across the domains assessed in MRCOG, especially in the communication domain and also the clinical governance topic. Slide, please. So what makes SIC unique? The first is about module mindsets. Module mindsets and how to apply it. No other courses have this, and module mindset is your key to success for the exam. Because we know that there are 14 modules, but they will not actually tell you what module this is. So you wouldn't, in the real setting of the exam, you wouldn't know if this is a postpartum or antenatal care or maybe a post-op complication module, but you need to identify the correct module mindset in each scenario. Okay, so it is most important. You can get a topic that you've never heard at all for the exam, but if you have the correct mindset, if you have the correct template in your mind, you can still pass the station. And my exam experience, there was a case of a postpartum complication and also an antenatal care case that I've never heard, I've never read about before. But then I just kept calm in the first 2 minutes, and then I used the right module mindset, and everything went smoothly. And give me any scenario, I can tackle it with the correct module mindset.
May I just add one thing here, with your permission, Dr. Fernando?
Sure.
So I was just thinking when you were talking about the module mindset, that it can be, they don't tell you which module it is.
Yes.
Maybe people might be thinking, or somebody might be thinking that they would know if it's an antenatal case. Why wouldn't they know? Or they would know that if it's a delivery case. But quite often it's not. For example, if some patient, if the scenario says 8 weeks pregnant, it could be early pregnancy complication, it could be gynecological module, or it could be antenatal care module. So it's not really, the topics really do not depend. They are very, very confusing. Topics cannot define the module mindset. So module mindset is something completely different. It is not what is in different modules in the RCOG curriculum, but it is how the systems work and how things are managed through a certain pathway. That is the definition of module mindset.
Yes, thank you, Dr. Asma. So, and the last thing is the detailed feedback and the continuous improvement in the span of 8 weeks. I remember I kept asking Asma how my baseline was, how I was in the beginning, and and Dr. Asma told me, "Don't worry about it, just keep going." And then she had faith in me, especially, and then she sent me a teddy bear. See, Dr. Asma likes giving gifts, and this is a good luck teddy bear that I passed my exam, and I passed my exam, and I still have the teddy bear with me. So yeah, initially I had no idea on how to open or start a consultation for the exam. Mainly focused on the topic itself. I read on diabetes. I focused on other diseases, forceps teaching and such. But as you go along, it just starts flowing. Okay, in the first few weeks, it is quite difficult to adapt, but you will get along, and then in the next modules, all of it will start flowing smoothly. So the constant practice is also really important. And if I may add something, Dr. Asma, because we are also in an online setting like this with this go-through meeting, it is very important that all of you guys familiarize with the technology, because during the real-time exam, this is also what happens. Okay, you will need to log in. You need to use a headset and such. You need to have a good connection. You need to show your face clearly. So being prepared for all of this in 8 weeks, I'm not really anxious about the exam from the technology side anymore because I'm familiar with it. So next is Dr. Umara. I'm going to hand over the stage to you. Thank you.
Thank you very much, Daryl. Basically, I think they will be shifting to the to physical exam once again, but you never know because COVID is still going so up and down. But still, technology will be required. For example, the time of submission, the application submission, how you are going to submit the fee, and so technology plays a lot. And in the syllabus, IT is one of the modules as well. It is not assessed in part 3 as such, but having information technology at your fingertips is a very important requirement of the present age, regardless of what specialty, what field you are working in. Thank you very much for your sharing your perspective, and I would like to welcome Omara Ahmed, Dr. Omara Ahmed, to please give us a little talk.
Thank you very much, Dr. Asma and Dr. Daryl. So before I introduce myself, I think it will be unfair if I don't appreciate Dr. Daryl because he was an amazing student. I have seen him transformed in 8 weeks. I would say that the way he was following the feedbacks without taking it personally, that was really, really good. And that helped him to, gather the weak points and to see where he needs to improve himself. And within 8 weeks, he was ready to go for the exam anytime. So that is one point I have to emphasize, that do not take any feedbacks at a personal level. These are very honest feedbacks which are given at SIC. And as Asma said, if you follow all the rules, the 100% pass rate is our course star mark. So now coming to my introduction, I have a diploma in healthcare education and professionalism, which I did after passing my MRCOG exam. I have a fellowship from College of Physicians and Surgeons, Pakistan as well. So why did I do a diploma in healthcare education? The first thing is that I am a very I would say, I'm very fond of non-technical skills. So when I was preparing for MRCOG exam, and when I started actually preparing, I had no idea about clinical governance. That was something I would just close my eyes and run away from it. I tried learning through the guidelines, through the Google articles, but I just could not get hold of that part. So when I started preparing for MRCOG, and especially after joining the MRCOG, I realized that this is something which is very, very important in our day-to-day practice. And Asma somehow made it so much easy for me to have a basic concept of clinical governance that I was just a fan of this. And after clearing my MRCOG, I took a diploma in healthcare ethics and professionalism. And I was really surprised to see that this is what MRCOG is basically looking for. It's a behavior and an attitude which they want all the clinicians to adopt with the practice and with the exam. It's a major part of non-technical skills. So that is the reason I am very proud of having a good understanding of this concept, and I'm all willing to impart my understanding and knowledge to everyone who comes and becomes a part of our Smart Intensive course. I have fellowship from Pakistan as well, and those coming from Pakistan, a good news is that the exam format is going to be exactly the same as MRCOG. So preparing for one exam or in one style, you will be able to actually pass 2 different exams. So this is actually a good news. Now, my MRCOG journey is quite interesting. It was a very bumpy road. Like Dr. Darrell said, he passed his MRCOG in first attempt. So I will also say that I passed my MRCOG in first attempt. But that first attempt was actually after joining BMRCOG. And in fact, that was my 4th and final attempt overall. So what happened is I was one of the candidates who were the first one when the format changed from the old OSCE Part 2 style to Part 3 style. So I did first two attempts 6 months apart. I was preparing with the persons who had actually attempted OSCEs, with the consultants who have done MRCOG in the old style, and that was what I practiced. I did not know if I'm doing it right or if I'm doing it wrong, because everybody says it's just MRCOG. You have to communicate, you have to talk in a preferred language, and just few things and tips which I practiced. But I actually could not understand what is the reason of my failure. So after failing 2 attempts, I started getting hold a little bit about, okay, I have to go through some modules. There are domains which I'm repeatedly failing. So I tried to attend a couple of courses. And then, you know, as you keep on failing, you keep on attending different courses, the anxiety levels goes really up. So what happened is, in my 3rd attempt, although I had some idea about the modules, but my anxiety level was so high that actually I had mental blocks during the examination. Like, I was sitting in front of the examiner and simple words I was not able to say. Like, I completely forgot that what is oxytocin. So you can imagine the level of mental block which I had on the day of exam. So that was definitely a failed attempt. The more I tried to dig out what is happening, the more I ended up mixing up everything. So I joined BMRCOG. It was also, I would say, a hit and trial. One of my friends recommended. I said, okay, I have attended and subscribed to so many courses, so let me try this one as well. So actually what happened is I joined 2-3 courses, and after a couple of 2-3 sessions, I just opted out because they were all feeding with specific sentences, with the, like, if there are 10 or 20 attendees, they wanted everyone to say the similar thing in the similar style, and that was not acceptable for me. I wanted to be in my own style. I wanted to be spontaneous, so I just quitted those courses. Like I said, a hit and trial, I said, okay, let me join BMRCOG. What will happen? I will attend 2-3 days and then I will quit if I don't like it. But then since that time, I am just with BMRCOG. I passed my exam after the first attempt. Even that 4th attempt was after 1.5 years of gap. But after attending this course, I did not have any anxiety. I just walked into the exam like my daily practice, and I passed it. Plus the skills and drills, which is a very unique format here at BMRCOG, that made me very, very confident how to deal with the emergency scenarios. because emergency scenarios are something like we feel that we have to speak very quickly, we have to be very loud, we have to show with our body language, which actually shows more anxiety than the knowledge. So I learned how to deal with these scenarios. So next slide, please. Yeah. So I'm working, as I told you, as a co-moderator. And my perspective for this MRCOG exam, what I learned through repeated exams and after joining BMRCOG, that justification of any topic, any scenario is all what they are looking for, because the safety domain is the most important thing which has to be covered. So it is all about what, why, how, and when. So the candidate, and if it is a simulated patient task, or the examiner, they have to be on the same page. So this is important. You have to use as simple language as possible, especially because majority of the scenarios now have lay examiners, so that is very important. You have to be very, very confident and don't be anxious, because anxiety is a killer. So to overcome my anxiety, I actually took some sessions through Doctors in Difficulty. I had few counseling sessions, and that's how I actually found out that anxiety is a major cause of my failure. And I overcome that anxiety, just became spontaneous. The transformation I had after joining BMRCOG, it was really an amazing journey. So next slide. So for the tips and tricks, which I would suggest for everybody, is that knowing something and expressing what you know are two different things. Let me give you an example. Like, one of the scenarios was kind of breaking the bad news, where a patient had a mishap, and after a lot of events, she ended up in a hysterectomy, sepsis, and she was in ICU. Candidate was asked to debrief to the husband. So when I entered the station, there was a guy who was just holding his jacket, was in his lap, and he was just holding his head and looking down. I started talking to him. I took the consent, explained a little bit, and within like 5 to 6 minutes, I explained the whole scenario. And then it just clicked to me that this guy is not having any eye contact with me. He's just sitting down with a bowed head and holding his head. So then I realized, no, this is something not going right. So I just stopped there. I told him that you look really exhausted to me. And would you like to eat something, or you want to have some sleep? Then he became a little bit, he straightened up and he still did not have an eye contact. And then I told him that, see, you have gone through a lot, and there is, your wife needs your support. You have to be strong to support her. So it would be a good idea to go home, get some sleep, and come back when you are fresh. Your wife is in ICU with the best nursing care. I am on duty throughout the day, and if anything changes, I will make sure that you have been informed and updated. So then immediately he just, he sat straight, he looked into my eyes, and he said, yes, I am really exhausted and I want some sleep. Is it possible? I said, yes, don't worry. Just leave everything, go home, get some sleep, and come back. So when I said that and he had an eye contact, I saw some smile on the examiner's face. And then I realized that, yes, that's what they were looking for, the empathy towards, not only towards the patient, towards the family as well. And that was the point, that was the exam. When I came out of it, I realized that, yes, I have actually transformed myself. I'm not the old Umara which just used to tell things, okay, do this, don't do that, this is right, this is not right. This is the transformation which I received from BMRCOG. And I'm really, really happy to transfer this skill to anyone who comes. Yeah, and that's how I learned. I tried to practice, and practice every day. I tried to use these techniques in my daily practice. I sometimes, when I feel that patient looks stressed, family is in stress, I will just give them extra few minutes. You do not need a long half an hour, 1 hour consultations. It's just few minutes that make a difference. So try to practice that. Communication is the most important skill. By attending different workshops at BMRCOG, I developed that skill. Communication skills workshop is a very, very effective workshop, and I learned a lot from that workshop. Empathy is my favorite word. So those who have attended any previous workshop, these group practices, and Dr. Darrell will be familiar that empathy is my favorite word. And in the feedbacks, that is what I always look for. And there is an empathy workshop which is worth attending. So my message is those who will be joining us for Smart Intensive course, enjoy it. You are going to have a completely new learning experience. No other course will provide you that, and you will never have it anywhere else. You will love it. And as Dr. Darrell said, it's not just the friendship or the exam, it's what we call BMRCOG family. Thank you so much.
Thank you very much, Umara. Just 1 second, please. So I would just like to talk a little bit about the case that you just mentioned. So just a simple example that when we are given such kind of a scenario in the exam, it's very common to have that task that to break bad news to a family member. And it's usually about post-cesarean hysterectomy to a young couple. I personally myself had that kind of scenario in the exam, and I remember very well, he was quite a young looking gentleman, not making any eye contact. And of course, I was trying everything that I knew in my first attempt when I did not pass. Of course, there's a time pressure. You have a task, a very difficult task to handle. You have to go through all the clinical governance elements. You have to encourage them about what is that called? The complaint process. You have to justify that the doctor who did was competent, because they will question that, okay, was that person competent who did this? Why this happened to my wife? They will be angry. You have to de-escalate anger. There's so much. You have to plan the post-operative, the intensive care management. Then you have to talk about the post, the breastfeeding issues, the contraception, and the future fertility. So much to deal with. But so you are so focused on that, and that you just don't find a way to a shortcut and how you can quickly do those things. Now, after knowing the right way to do it, and especially after working in this country, in reality, what it happens. Why I'm talking about reality is because this is exactly what they say, that they want us to reflect our day-to-day practice in the exam. So what happens is that if this kind of situation arises, we actually offer them a seat. We take them to a quiet room. We offer them a cup of tea, water, and also, we put them in touch with, if I can do it myself, but of course this is something that they will need to, the other staff members will need to do, but we talk them about the parking tickets, how can they get the discounted parking, where the cafeteria or the canteen is, where they can get food, where is there a place to sleep, or if they can go home. We check with them the transport, are they, because of course there's they have to pay for the transport. So it's a very, very different kind of conversation that you need to do with them. And yes, this is a part of it as well. But under the pressure of exam, if you are not aware of what empathy is, now asking these questions, I'm empathizing with the other person by understanding his circumstances, that how is he going to cope with what is happening with his wife, right? So when there is a relative, the focus of empathy is completely different versus when there is a patient. So it's just a small example to say that how things are, the cultural, what I was saying, the language that you need to use is different. The cultural norms are very, very different than as compared to other systems and all that stuff, right?